My guest today is Danielle Kunkle Roberts. Danielle is a founder of Boomer Benefits, a national insurance agency specializing in Medicare-related insurance products. Danielle is a nationally recognized expert on Medicare insurance. She is a Medicare Supplement accredited advisor and the past president of the Fort Worth chapter of the National Association of Health Underwriters. She's also a member of the Forbes Finance Council and has been featured in Business Insider, Yahoo Finance, MarketWatch, and CNBC, among other publications. And she is the author of an upcoming book called 10 Costly Medicare Mistakes You Can't Afford to Make. Danielle, thanks so much for joining us today to share insights and tips all about Medicare.
My pleasure, Andrew. Thanks for having me.
I'd love to start just by getting a little bit better sense of your background. How did you get into becoming an expert on Medicare and Medicare enrollment consulting and Medicare insurance?
Sure. So I had an insurance license, and way back in 2005, I used to work with people doing group health insurance and individual health insurance plans. And we noticed that people would always be asking about their parents. So they would get their own insurance squared away, and then they would come back to us and be like, hey, my mom's turning 65 and I can't make heads or tail of this stuff. It's crazy. What do we do about this? And a few times we said, well, we don't work with those products, and we tried to find people to refer them to. But after the question came up enough times, we're like, we should probably look into this. Let's see why is this stuff so confusing? And sure enough, it's just a beast of a national health insurance program with 4 parts and 10 supplements and literally thousands of different drug plan and advantage plan options across the United States. So we could see that there was a good opportunity here to become an expert at something and, take all of that confusing insurance language, boil it down into real terms that people could understand, and then help this wave of baby boomers that was getting ready to come through Medicare, 10,000 people a day aging in who are going to need help with understanding all those things. And it slowly just took over our business to where now, for many years, we have just focused solely on the Medicare population. We help them learn Medicare, get all the basics down, understand what their federal government benefits bring them, and then help them make supplemental choices for coverage that fills in the gaps. And we've helped over 50,000 people now over the course of that 15 years with making their Medicare decisions. And that brings us to where we are today, where I know, a little more than average person on the street about Medicare.
Okay, great. So, most folks understand, I think at a high level, Medicare is the subsidized, very affordable and universal health insurance program in the US that covers healthcare for seniors, or in some cases, disabled persons, largely funded from Medicare taxes that are deducted from wages, and that this federal subsidy covers, call it 75 to 99% of actual costs. But if you could maybe give us a high level overview, what are the key eligibility requirements for Medicare?
Sure. So one of the things that's important to know is that your Medicare eligibility is not the same as your Social Security eligibility. So you achieve your full Social Security benefits when you reach your retirement age, which is based on your birthday, and for most people is around 66 and a half to 67. And Medicare, you are eligible for at 65. So whether you start your Social Security early at 62 or you delay it till 70, regardless, you're eligible for Medicare in the United States when you turn 65. And as long as you have worked at least 10 years and had FICA taxes taken out during those years, your Part A hospital benefits will be provided to you at no monthly premium. You don't pay a premium for those. But your Parts B and D, you will pay premiums for. And so although you're eligible for Medicare at age 65, there's parts that you have to sign up for and decisions that you need to make. And I should also mention that there's a certain group of people that can qualify under age 65. So if you qualify for Social Security disability and you're 40, you'll be eligible for Medicare 2 years into your disability income benefits being paid out to you. And then there's certain health conditions as well that can qualify you for Medicare early. But the main group, of course, the way it was built in 1965 when Medicare was launched, was for people to age into Medicare, which today that age in is at 65.
Got it. Okay, so one question I'm curious about. One of the members in our private Facebook group, we have a private Facebook group for the Hack Your Wealth website, was recently asking about what options that they have if they live their entire adult lives abroad, outside the US, working for non-US companies, let's say, where they haven't necessarily been paying into Medicare taxes. In that situation, do they have any options when it comes to being eligible for Medicare, or are they pretty much out of luck?
Yeah, if they're back here and living in the United States, they can still sign up for Medicare. They'll have to pay for Part A. So although most people, about 99% of all people, will qualify for Part A being free. If you have worked less than 40 quarters, you can buy into Part A. So if you have partial credits, which a lot of people do over 30 quarters but not quite 40, you're going to spend somewhere around $250 for Part A. And if you have less than 30 credits, and so you're really not going to have even a partial prorated premium, it's going to cost you, it's getting close to $500 a month for that. Now, you may be married to someone, though, that does have the work credits. So if you are married to someone who does have that work history, you can get your Part A for a zero premium through your spouse, provided that a couple things are met, which your spouse has to be at least age 62 and eligible to receive Social Security, and you have to have been married for at least a year.
Okay, gotcha. Okay, so broadly, what does Medicare actually cover in terms of inpatient, outpatient, and drug coverage?
So we're very lucky to have the drug coverage today. We didn't have that prior to 2006. So over 40 years, people had no drug coverage on Medicare, which was scary. You could have your inpatient drugs covered, but no outpatient. Today, we're very lucky to have Part D, which is an optional program to get coverage for prescriptions. But the two original parts, which are your Part A inpatient hospital and Part B outpatient Medicare medical, have been around since 1965. We refer to them together as original Medicare or traditional Medicare, and they cover pretty much anything that is medically necessary. So diagnosis and treatment of a variety of health conditions and illnesses, pretty much anything that a doctor would order that it's obviously important for you to have medical treatment for is going to be covered by Medicare. Now, there is a little bit of a caveat in that, in the sense that in the 1960s, when Medicare was created, preventive health care was not the same and as it is today, and also ancillary health care is not the same. So today, we're used to getting our dental, vision, and hearing insurance through our employers, but back in the 60s, that was not common for that to be included in employer coverage. So today, still, Medicare does not cover routine dental, vision, and hearing. Now, they'll cover if you have glaucoma or cataracts or some other disease of the eye as anything else. What they're not going to do is cover for you to go get a new pair of prescription lenses each year, and they're not going to cover your routine dental visits. You need to have your own hearing test. If you need hearing aids, you're going to pay for those yourself. Original Medicare isn't going to cover that. And Medicare also has a few things, like it doesn't cover routine foot care unless you have a health condition that requires it, like diabetic neuropathy. And of course, it's not going to cover things like cosmetic. You can't go and have Medicare take care of your Botox for you. It's not going to cover fillers or a facelift. I know we ladies probably wish that we could get that done, but it doesn't cover those things. And one last thing that's really important to know that it doesn't cover is long-term care. So Medicare will cover short-term care when you go into a skilled nursing facility after a hospital stay and you're on the mend, and the goal is to get you back to able to care for yourself. It doesn't pay for the rent that you pay monthly to live in an assisted living or nursing home when you're at a later stage in life and you're not going to be returning to caring for yourself on your own. So really important, all the folks that listen to your podcast and are hacking their future wealth benefits, they need to know that long-term care is something they need to save up for separately, or they can purchase insurance, which is what I helped my parents do, so to pay for a future long-term care need if that ever arises.
Gotcha. Is there somewhere where folks can, see definitively what is considered medically necessary? Because there's some things that are clear, bright lines, like you mentioned, cosmetic surgery on the one hand, maybe an emergency surgery, an actual emergency surgery on the other. But there might be like a gray area where is it medically necessary, or does it like drastically improve quality of life, but it's not going to kill you right away? I'm just curious, like if there's somewhere where folks can actually see or determine with certainty what is considered medically necessary.
There's a couple of resources that you can consult, and then always the best resource is to ask the physician that's ordering the treatment. So, okay, hey, you've suggested that I have this surgery. Is this something that Medicare has covered for other patients for you in the past? If your physician gives you an advance beneficiary notice that tells you, hey, if Medicare doesn't cover this, you still owe it, that's always a sign of, oops, we better make sure that this is going to be covered. Medicare has on its website, there is a Medicare coverage page where you can actually type in the item medical supply or healthcare service that you're about to get. And it'll bring up all the pages on Medicare's website where you can read about what is covered. So for example, if you were to go to that page on Medicare's website, and I can provide the link for your listeners if you like, you can type in colonoscopy and you'd be able to bring up a screening colonoscopy and see that it's covered once every 10 years or once every 2 years if you're considered high risk. That's a great tool to go to. Medicare also now has an app for your smartphone. It's called the What's Covered app. So let's say that you're at your doctor's appointment and he's suggesting something. You could literally go right under the app on your phone and search to find out a little bit more information about what's required. Pretty much anything medically necessary will be required to be covered by Medicare, but a lot of things do require a doctor's orders or some sort of prior authorization. So for example, you can't just go to a skilled nursing facility and check in. You have to have had a qualifying 3-day hospital stay first before Medicare would cover that. Same thing with physical therapy. There's going to be a doctor's order that needs to happen, and then there's going to be documentation about why that thing is medically necessary. So there might be something where you decide that it's covered, but it's not like you can just waltz on off yourself and go and get that coverage. You need to be working with a Medicare provider. Anything that's ordered by a doctor that's not a part of Medicare is also going to be something that may not be covered. You might have to file your own claim for it, or Medicare may not cover it at all. So those are a few resources. We have a YouTube video called Will Medicare Cover My Procedure? And in that video, I go over a lot more detail about kind of determining if something is medically necessary or not.
Got it. That's really helpful. And yes, please send me the YouTube video link. I'll link to that in the show notes for sure.
Okay.
Are there any network restrictions in terms of doctors, hospitals, clinics, pharmacies that you can go to? How does a Medicare recipient determine which providers will accept their Medicare insurance?
So a lot of the physicians in the United States do accept Medicare, and if you have been treating with them prior to 65, they'll usually transition right on over to Medicare with you when you turn 65 and get onto Medicare's coverage. A lot of clinics out there have a balance of patients, and so they may get full on Medicare patients, meaning Medicare pays less than what under 65 insurance companies pay. And so most doctors' offices like to have a mix of Medicare patients and also under 65 patients. So the only time you're going to run into a real problem with finding a Medicare provider might be when you move to a new town. And it's not that the doctors don't accept Medicare, it's that they have practices that are already full. You can go to Medicare's website and they have a directory there where you can search for Medicare doctors. The good news is about 93% of all physicians, according to the Kaiser Family Foundation, currently do accept Medicare. So most of the time you're going to run into these physicians accepting it. The question you need to say is, do you accept original Medicare? And if the doctor says yes, then you're good to go treating with them. There are some doctors that are considered non-participating providers, and what that means is they will bill Medicare, but they reserve the right to balance bill you up to 15% beyond that. And so the question then that you're asking is, do you accept Medicare? The doctor says yes. Do you accept Medicare's assigned rates? If he says yes, that's great. If the doctor says no, that's one of those physicians that could do the balance billing. And there are solutions for that. So for example, you can enroll in a Medicare Supplement Plan G, and that is going to take care of any of those excess charges, so you don't have to bother answering that question. The other thing people need to know, and I'm sure we'll get into this, but once you're on Medicare and you're making a decision between a traditional Medigap plan or a Medicare Advantage plan, the Advantage plans have networks, and those networks are much, much smaller and more local than original Medicare, which is going to cover you at over 1 million providers across the US. So if you decide to go that route, you're going to have a little bit of extra homework you need to do up front in determining if the doctors that you see participate in the plans that you're looking at.
Gotcha. That's really helpful. So you mentioned that some doctors may bill you the back to balance, and so it's important to ask if you don't have Part G. Is that just up to physician discretion, or is there a regulation around who can?
There is,
like who can do that?
yeah.
I guess.
There is some regulation around the fact that they can't just bill you anything they want. It can only be up to 15% more. And most doctors don't do that because, of course, it's extra work for their billing staff. It's easier just to accept Medicare's assigned rates and let it go. But this is kind of a stepping stone maybe to where if you've got a doctor who literally would just stop taking Medicare patients because he can't make ends meet, he could decide to be non-participating, do the balance bill a little bit more, and that may keep him involved in the program. So that's why it exists that way. So it's always just a good question to ask if you have original Medicare and you don't specifically have a Medicare Supplement Plan G, which covers the excess charges. Plan F also covers excess charges, although that plan is no longer available to new beneficiaries. It's only some existing beneficiaries that have been on it. Then you don't have to worry about it. But let's say you went with a Medigap Plan N, which is one of the newer Medigap plans. They can bill you the excess charges there. So although that Medigap plan has lower premiums and the more full coverage you would get with like an F or a G, there's that chance there that you could have the balance billing. And so then you're just deciding, do I want to go through the work of asking each of these doctors this question? Sometimes it can result in a little balance bill that comes in the mail for $3 or $10. But if it was a more expensive procedure, it might result in a bill that's $60 or $70. If that's going to be something that would worry you or irritate you when that bill comes in, it's sometimes a good idea to go ahead and enroll in a supplement that's going to take care of that for you. If you go the other route with the Medicare Advantage plans and the networks, that question doesn't come into play because those plans have their own rules about what they pay their providers. And so in that situation, you wouldn't need to ask that question. It would more be about, are they in the network for that particular plan?
Okay, perfect. Traditional Medicare comes in Part A and B, and now there's Part D, each of which has separate premiums. Can you help us understand what each of these three parts really are and how they work, including the premiums or premium ranges associated with each for, say, a senior who is just trying to get oriented to Medicare?
Yeah, really good and so important for them to know too. One of the things that I cover in the book is so many people enter Medicare and they have no idea that it costs anything. So if you have literally been saving for retirement your whole life and you didn't know that you needed to have $300,000 set aside for healthcare in retirement, this can be a rude awakening. So knowing what they cost is important. We covered earlier that Part A for most people who've worked in the US is going to be a zero premium. And then Parts B and D have premiums. So for Medicare Part B, which is your outpatient coverage, around 94 to 95% of all Medicare beneficiaries will pay the standard base premium, which in 2020 is $144.60 per month. That is what most people will pay. However, if you happen to be one of those people who is in a higher income bracket, then 5 to 6% of the population pays a higher Part B premium based on that income. And there is a Medicare costs page on the Boomer Benefits website where you can see a chart. You can look up your income. You'll see exactly what your premium is going to be. These change a little bit each year. So Medicare typically raises the cost of Part B a little bit each year, and some of those thresholds may change. But if you're just ballparking, what do I think I'm going to spend on Medicare in a few years? You could plug in $144 roughly for Part B is what you would spend if you were getting in today. And then Medicare Part D, which is optional, but is recommended if you have prescriptions that you're going to need to take. The average Part D plan in the United States is around $32 a month. So there are plans cheaper than that and plans much more expensive than that. But if we were taking an average of everyone across the US, that's a ballpark. So if we add those two figures together, you're at around $175 to $180 a month that you're going to spend on your basic Medicare. And then in addition, you're going to need either a supplement or an Advantage plan to help fill in the gaps. So Medicare does not cover 100% of your healthcare costs. And really, this shouldn't be too surprising because if you think about the insurance you have now, the same situation applies. You have a monthly premium that you pay for the coverage, either through your employer, you might pay like 20% and they deduct that from your payroll checks. Or if you have an Affordable Care Act individual health plan, you're paying a premium to that insurance company for your health care coverage. But when you go in to use the coverage, you still have things like a doctor copay or a deductible in the hospital, and Medicare has those same things. So if you go into the hospital, you'll be covered for the first 60 days in the hospital, and the only thing you'll pay is a deductible, which currently in 2020 is around $1,400. I think it's $1,408. So first day, one night in the hospital, bam, you can totally expect to pay that unless you have a Medigap plan that's going to cover that for you. So that's what you would spend, but that's going to get you 60 days in the hospital where they're covering doctors and nurses that check on you, your medications that are administered to you, all of that care that you're receiving. So it's pretty good. Now, if you're unlucky enough to stay in the hospital past 60 days, you'll start paying a daily copay that gets bigger with time, and then your benefits run out at 150 days. After that, you would pay all costs. Now, I can tell you as an agent who's done this for 15 years, we almost never see someone that exhausts that whole 150 days. It's very rare, but it does happen. So purchasing a Medigap plan will get you another 365 days covered in the hospital, which is usually more than enough for anyone will need for a lifetime. On the Part B side,
is that a lifetime limit or an annual reset?
So every time you go into the hospital, let's say you go into the hospital on, say, April 1st, that's going to kick off what's called the benefit period under Part A. And that benefit period typically runs for 90 days, but it doesn't close until you leave the hospital or skilled nursing facility and you've been out for a full 60 days. So if you're in the hospital, let's say you are in the hospital 90 days and you get to day 91, those last 60 days from day 91 to 150 are lifetime reserve days. You only get them once. So if you use 10 of them on that one hospital stay, then in the future, you only have 40 days left. I'm sorry, there's a total of 60 lifetime reserve days, so you'd have 50 left. Most people don't exhaust those. The good news is when you leave the hospital and you've been out for 60 days, when you go back in, the whole thing resets and you're on a new benefit period, but that's only the first 90 days. You have those lifetime reserve days that can only be used one time during a lifetime, either all at once or sprinkled out. But because the benefit period closes and resets, there's not a lot of people who have very long consecutive day hospital stays, so we don't see people running into that too much. And then, of course, a Medigap plan will give you all those extra days to where you're really not worrying about it too much. More people are concerned about getting to day 60, and then they're paying a daily hospital copay around $350 a day, and that continues to get bigger with time. So we want to have plans in place that are going to cover those things so that you're not trying to get well, but you're in the hospital worrying about what kind of bills are going to be in your mailbox when you get home. So there's your Part A, kind of what you would spend on that inpatient side. Let's say you are in the hospital for 10 days and then you're better, but you still have some wound care going on. And the doctor says you can leave the hospital, but you're ready to go to a skilled nursing facility before you would go home. That's okay. He can transfer you there, and Medicare will cover the first 20 days in that skilled nursing facility at no cost to you. But on day 21, you start paying $176 a day. On day 100, you run out. And so, again, these costs can be pretty big if you actually do hit them. And then there's a limit to how long that those costs will go. So if people don't know that going in, and then they don't get better and they kind of devolve into needing long-term care, there's going to be a point there where that benefit runs out and now you're into paying for your own costs of an assisted living or nursing home. And those are things that we need to plan for.
Gotcha.
Although I was going to say these numbers.
Yeah, go ahead. You. Go ahead.
These numbers are scary, right? They're big numbers and they freak people out, but we don't see people running into them quite as much. It's more on the Part B side, your outpatient care, where you're going to incur more of the costs that actually happen on a day-to-day basis. You go to the doctor. Medicare Part B is going to cover 80% after an annual deductible. That deductible is only $198. My deductible on my health plan is like $6,000. So I would love a $198 deductible. That's on the Part B side. So the first $200 out of pocket you're going to spend. After that, Medicare covers 80%, which is good. So you pay the other 20%. And that's not a big deal on a doctor visit, but it is a big deal if you're having a CAT scan or dialysis or chemotherapy. And the bad thing is that 20% goes on forever. There's no out-of-pocket limit. There's no cap to protect you. And so we want to have a solution for covering that other 20%. And that's where brokers like us come in with plans where you can cover these deductibles and coinsurance percentages that I'm telling you about. But to get back to your original question, knowing going in that Medicare isn't free and it doesn't cover 100% of your costs, just knowing those two things before you get to age 65 puts you ahead of 90% of the other people out there. We see them come in at 65 every day not knowing any of this. And knowing it when you're younger, when you still have time to save and plan and have compound interest to pay for those future things, is really important.
Okay. In Part D, is there anything you would comment on Part D?
Yeah. So Part D is fabulous from an insurance agent perspective, because I remember what it was like in 2005 when I would have a client that needed $10,000 a year of diabetes medicine and I had to tell them they were going to pay for it all out of pocket. It was horrible. So we're really happy to have Part D. That said, Part D is a confusing animal. It has 4 different stages, including a deductible upfront that Medicare sets every year, which currently is around $435 a month, $435 a year. So you can imagine if you're used to just going in and paying a $10 copay on your group health insurance plan, and now you've got to cover the first $400 something in drugs out of pocket each year, and you're on a fixed income, this is not something that seniors are crazy about. So you need to know that going in. It's not perfect. There are some things like deductibles. We hear about the coverage gap, which is the time in the year where if your drug spending goes too far, you pay a little more for the drugs than you might have paid before. But overall, the best thing about Part D is even if you enroll in the cheapest plan in your state, which is maybe $10 or $15 a month, all of the plans have catastrophic coverage that kicks in to protect you when your limit on your spending hits a certain amount. So currently, if your out-of-pocket spending between what you've paid and what the insurance company discounts are reach $6,350, then you're done spending for the year at that level, and now you only pay no more than 5% of the cost of your drugs for the rest of the year. So that's good and bad, right? One, it's good because it's going to greatly reduce what you're spending, but it's bad because, wow, you didn't get there until you spent $6,000 plus dollars. These are things that people don't really like about Part D. So when you're coming off of employer coverage and you're getting ready to go on Part D drug coverage, you're going to want to research ahead of time, work with an agent, give them a list of your medications, have them run an analysis and give you a ballpark estimate for the plan that's probably going to be best for you costs this much. And here's the copays you would pay on your specific medications at different parts throughout the year. And this will help you know, like, do I have enough money set aside that I can go ahead and retire now and this will work for me? Or, wow, my drugs are going to be really expensive once I get on Medicare. I need to work a few more years and put some money aside, being prepared for that. Or maybe you save money in a health savings account and you rack up those dollars over the years so that you have that available for your drug copays when you get ready to retire. All of those are good planning strategies to be ready for Part D, which is better than what we used to have, but certainly not perfect.
So it sounds like Part D is pretty complicated. Or is there an equivalent Medicare website estimator where folks can kind of get a sense of what their cost sharing liability might be for Part D?
Yes. Yeah, so even though you can't buy Part D directly from Medicare, you buy it through insurance companies, Medicare does have a plan finder tool on its website. So if you are already 65, you can actually create your own portal. It's called mymedicare.gov. And you can go in and enter your medications and save them so that you can update them each year. And right in that portal, you can run a list of all the drug plans available in your county and exactly what they cost. And you can rank them by your total annual cost. That includes everything, your premium, your deductible, your copays, everything you spend. And it'll tell you which plan is going to cost you the least amount of money over the course of a year, all the way down to the plan that would be the worst one for you. And then you can choose. But if you're not 65 yet and you don't have a mymedicare.gov portal, you can go to just the regular medicare.gov and use the find a drug plan feature. It's called the plan finder tool. That one doesn't allow you to save the medications because it's open to the public, but you could at least do a preliminary search and maybe you find, hey, there's a plan in my area which is around $30 a month that looks pretty good. I'm going to work with my financial planner and write down $30 a month, and that's what I'm going to ballpark that I'm going to spend on my drug plan someday. And here's what my copays are, so I know I need X dollars set aside to pay my prescription copays.
Got it. Okay, I'll definitely link to those in the show notes too, man. A lot of good resources here. So if I'm synthesizing correctly, it sounds like at least the philosophy behind the way you just described how Medicare's Part A and B are structured are it's meant to cover you when you're sick, but when it starts to look more like long-term care, then that's when it sort of sunsets and you need to find some other, insurance arrangement. Is that an accurate kind of high level assessment?
Sort of. So it's important to understand that even after you live in an assisted living or nursing home, Medicare is still going to pay for all of your medically necessary medical care. Doctor visits, hospital stays, all those things are still going to be covered. Surgeries. What it doesn't cover is the monthly rent for you to live in assisted living or nursing home. And on the low end, those facilities cost $3,000 a month. I had a girlfriend that was paying over $8,000 for her parents in a facility. So that's the part that it doesn't pay for. So you no longer have a mortgage on your home because you're not living in a home anymore, but you're living in a center where you're paying. And so you're either going to private pay that and be exhausting the savings that you've made over a lifetime, or if you do exhaust all of that, you can apply for Medicaid, which is government assistance for health items for people with low incomes. And that will help you to get into a facility that has a semi-private room, so you'd be sharing that with another person. Obviously, it's better if you have the funds available to make your own choices, but that is something that would be the option if you ran out of all the money and you had no way to pay for it. Then Medicaid will stick in to pay for those things. But even when you live in assisted living or nursing home, Medicare is still going to pay for doctor visits and any other medically necessary care.
Okay, thanks for clarifying that.
Sure.
So when it comes to Part B and D, you alluded to this a little bit earlier, but it sounds like if your income exceeds a certain threshold, you start having to contribute more. I think this is what you're referring to, the income-related monthly adjustment amount, the IRMAA.
Yes.
Could you describe a little bit about how that works, when the
Yeah.
thresholds kick in, et cetera, and how much
Sure.
additional liability are we talking about?
So in 2020, the thresholds are 87,000 for an individual filer and 174,000 for married filer. It's important to know that everyone pays their own Medicare Part B premium. So let's say you and your spouse were underneath 174,000, you will each pay 144.60 out of your own personal Social Security check. They take it right out of your Social Security check if you're on Social Security by that point to pay for it. So that's 144.60 times 2. But if you're married and you're over that limit, or if you're single and you're over 87,000, then there's 5 levels above that. And I think the first level, your premium bumps up to around 202,000, and it goes all the way up to, sorry, my lights are going off in here on the overhead here. They're on a timer. If you get all the way up to the highest level, then it is almost $500 a month each. If you're married, they're still going to base it on your married income, but you each pay your own premium. So you could see that if you were in that high income bracket, you would pay substantially more for Part B, and they would also tack money onto your Medicare Part D drug plan premiums as well. So that can increase your drug plan premium. I think in the highest level, you pay an extra $72 a month for your Part D drug plan. And these are all factors that you need to know ahead of time. And something else is that they're going to base that on your income from 2 years ago, because the IRS is getting those records over to Social Security, and there's time that takes. People have delayed tax filings, things like that. So they're always looking 2 years back. Well, if you have retired since then and you were making more than the threshold, but now you make less, Social Security does have a reconsideration form that you can file with them, where they will look at the evidence you present of your retirement and they can adjust that down for you so that you're not always waiting for that next tax year to catch up. You can appeal that if you have retired and your income is now lower.
Got it. Okay, cool. So, one of the key takeaways I've been hearing is that really it is possible that your all-in cost, when you factor in premium, deductible, copay, it could actually be unlimited if you're in an unfortunate sort of set of circumstances. But I'm just curious to kind of get your thoughts. After you factor in all of the costs, premium, deductible, copay, what do you typically see the range of that someone can expect to pay monthly for Medicare coverage that includes all 3 parts, like on a spectrum, say low and high? Say on the low end, you're assuming you're healthy and retired, you're not earning any income anymore, so you're not paying any IRMAA, and you have low lowish deductibles and copays. And by contrast, on the high end, assuming you're, say, in poor health, but you're earning, and you're also earning a high income, you're paying sort of the maximum IRMAA along with high deductibles and copays. What do you typically see, just so we can get a mental image of like the typical person, even though, yes, it can be unlimited, but the typical person, what is that range that you typically see for the all-in cost?
Yeah. So we know that approximately 95% of people pay that lower Part B premium, around 144, and they can add a Part D drug plan for as low as $10 or $15 a month. And in a lot of the Midwest states and in Texas, you could add a Plan G Medicare supplement for roughly $100. So you're looking at, I usually give people a ballpark of roughly $250 to $300 per person for really full coverage that's going to have a $198 deductible, and then everything else is covered except for your prescription copays. That's a pretty good ballpark for a lot of people in, the average states. But there are some states where the cost of healthcare is higher. So if you live in New York or in Florida, Connecticut, there's some states where you might pay $200 a month for that same Medicare supplement. And in that scenario, you might decide to go with a Medicare Advantage plan. The Advantage plans in some areas have what's called a zero premium because you're agreeing to get all your care through a network. They're going to try to attract you to that plan by offering the plan for as low as possible. And some of them will charge nothing for the plan. Well, in that scenario, you're just paying for Part B. You've enrolled in an Advantage plan with a zero premium. If it includes a Part D drug plan, which there can be a built-in Part D drug plan and an Advantage plan, you might be only spending the $144.60 out of pocket, and you've got all the pieces there that you need. And you won't really know where you're going to fall within there until you start looking at the options, finding out which plans your doctors participate in, and deciding which route to go. Now, if you were on the other end of that spectrum, let's say you're at the highest end and you're going to spend, I think it's $490 something for your Part B premium, and you live in Florida with a $200 a month Medigap plan. You don't want to do the Advantage plan because you have a lot of health conditions and you want the fullest coverage that you can buy. You might be spending, what is that, $700, $750 a month for the coverage that you want, depending on where you live and what that income looked like. And you can see, just knowing that boy, these are numbers you really need to crunch well ahead of the day that you enter Medicare so that you can be prepared.
Okay, helpful. What is the initial enrollment period and how does the enrollment process work?
So if you're already taking Social Security, let's say you signed up at 62, and they are going to assume that because you are taking Social Security, you're no longer working. So they will also assume that you don't have access to group health coverage, and they will just sign you up for Medicare Part A and B at 65. Your card will show up in the mailbox a month or two before you turn 65. But if you have not yet taken Social Security, which is the case for more and more people today because they're delaying those benefits until their full retirement age or 70 to get a bigger Social Security benefit, then you need to initiate your own enrollment. And there is a 7-month initial enrollment window for Medicare that starts 3 months before the month of your 65th birthday, goes through that month, and goes for 3 months after. As long as you apply in the 3 months before, your Medicare benefits will always start on the first of the month in which you turn 65. So if you, even if your birthday was on the 31st, your benefits will still start on the 1st. Now, if you happen to be a person whose birthday falls on the 1st of the month, they're going to treat you like you turned 65 the month before. So let's say your birthday is June 1st, your Medicare could start May 1st. It's a weird little thing. It's something similar with Social Security like that too. But for the most part, you want to just think of that 7-month window with your 65th birthday being right smack dab in the middle. That's when you need to initiate an enrollment to avoid a penalty. If you don't enroll in Medicare during that time and you don't have other creditable coverage, like you can't say you delayed Medicare because you have large employer health coverage, then you would be subject to a late penalty, which can be 10% for every 12-month period when you could have been enrolled in Part B that you weren't. So if you just didn't know any better and you didn't have other coverage and you were healthy at age 65 and now you're 72 and you decide that you're going to go and get some coverage, you could pay a 70% higher premium for Part B for the rest of your life because you missed that initial enrollment period and you didn't have other creditable coverage. And this is the kind of thing that people miss all day long because they just don't know any better. and those penalties are with you forever. So again, super important to know this stuff ahead of time.
So that penalty is like when you said 10% per month, it's 10%, your premium amount will increase by 10% cumulatively. So in month 2, now it's 20%, and month 3, now it's 30%, and that persists for the rest of your life?
So it's 10% for every 12 months that you missed. So let's
Oh,
say,
got it.
yeah, let's say you just missed by 1 year. So you're going to pay a 10% higher premium every month for the rest of your life. If you missed it by 2 years, it'll be a 20% higher premium. But those premiums for Medicare do go up every year, and you're paying a percentage of that higher premium each year. So that penalty, it will grow with time.
I see. And I guess as a policy matter, it sounds like the reason that penalty exists is they don't want you to like be careless and get sicker when you could have had care, and so they make you cost share. And is that kind of the way to think about it?
Yeah, I think so. They want there to be some, punitive damage that you also incur, because if you're waiting, they need healthier, younger people paying into the system to keep the trust funds going for everyone that's involved, and they need a way to make you pay attention. So by putting a penalty out there, they know the word is going to spread, and people will be more likely to go and research that ahead of time so that they can get enrolled and not be in a situation where they don't have any coverage. Now they're relying on county assistance, or they have medical bills that never get paid back. That's what they're trying to avoid.
Makes sense. Okay, so we've touched on this a little bit earlier, but I'd love to dive a little bit deeper. So some retirees choose to opt out of traditional Medicare A and B, and instead they enrolled in Part C, which is what you talked about earlier, Medicare Advantage. What
Yes.
is Medicare Advantage in a little bit more detail, and how does it work?
So Medicare Advantage was designed as an alternative to Medicare and Medigap, because not everyone can afford a Medigap plan. So there were always people that would have just original Medicare, which is fine until you get sick, and now you got to pay 20% of chemotherapy, and you're very quickly filing bankruptcy for medical. And we could see that there needed to be another solution for people who would just risk it on original Medicare because they couldn't afford a Medigap plan. So with Medicare Advantage, you are agreeing to get your Medicare Part A and B benefits through a private insurance company's plan. And most of the time, these plans have networks. It'll be either an HMO or a PPO. So a Medicare Advantage plan looks very similar to group health insurance that you've had in the past. If it's an HMO, you're typically picking a primary care doctor. You need to see that doctor first to get a referral before you can see a specialist. Because it's an insurance company, there's going to be more prior authorizations that you have to get done with an Advantage company than you would with original Medicare. If you go the PPO route, those plans are a little more flexible. You can go out of network if you need to, but you're going to just pay more to do that. Whereas with an HMO, there's no out-of-network coverage unless you have an emergency with most HMO plans. And then there's some hybrids like an HMO POS, which is somewhere in the middle. But for the most part, those kind of two networks are the most common. And so you're deciding between a couple of things. If you stick with original Medicare, you have freedom of access to see any provider anywhere in the nation that accepts Medicare. If you travel a lot or you're a snowbird, you've got houses in 2 locations, you can see a doctor in Kansas, you can see a doctor in Arizona. These are all good things. And original Medicare, being the federal government, tends to rubber stamp a lot of claims. There's not as many prior authorizations and things that you would see with an Advantage company. But with original Medicare, you're going to need to really pick up a Medigap plan, which is costly. And so your option is maybe, let's say you're a really healthy person. You rarely go to the doctor. You rarely travel. And you have a plan right here from a Part C company offering a Medicare Advantage plan in your area. Your doctor's in the network. It has a built-in Part D drug plan. That's a bonus. Now you don't have to pay for a separate Part D plan. You might look at that and say, well, hey, I've been on HMO plans all my life. I'm okay with this. I don't mind getting a referral. And now I don't have to pay a premium for a Medigap plan, and this HMO plan has a lower premium or a zero premium. It can be very attractive to a lot of people. Advantage plans can also include things that Medicare doesn't, like gym memberships, dental, vision, and hearing coverage. Most of the time, those things are very limited, and it's important for your listeners to know that Medicare Advantage plans change their benefits every year. So you need to know going in don't join a plan just because you like a gym membership, because they could drop that next year. You want to have a plan that's going to cover you for the really important things, like how's it going to cover on cancer if something happens to you? What if you were in a terrible accident? You want to buy a plan that your doctors are in the network for. All those things need to be considered first. And then if you have a couple plans to choose from, one has a gym membership, one doesn't, then that might be where you make those decisions. But those are some of the things that people are attracted to Advantage plans over. What's really important for you to know this about is when you first become eligible for Medicare and you enroll during your initial enrollment period, your Part B effective date gives you a one-time 6-month window to buy any Medigap plan you want with no health questions asked. After that, in most states, to get a Medigap plan, you're going to have to answer health questions and they can turn you down for coverage. So let's say you're pretty healthy, you go ahead and you say, well, I'm going to go for this cheaper coverage, the Medicare Advantage. And now 3 or 4 years down the road, you get sick and the oncologist that you want to see is not in the network. So you transition back to original Medicare during the annual election period and you say, well, I'm just going to go buy a Medigap plan. Well, they're going to turn you down because you have cancer and they don't want to take that on. So if you go the Medicare Advantage route, you have to know that going in, that later on you can easily get back to original Medicare, but you may or may not be able to get a Medigap plan in the future. So this is a big decision you're making up front. You need to really think it through when you're deciding between original Medicare and Medigap and a Medicare Advantage plan, because it could be a situation where you start with one kind of coverage and you can't get back to the other kind of coverage later. I will say a thing about Advantage plans that is really great is they don't have health questions starting in 2021. Even in 2020, they have one health question, which is, do you have end-stage renal disease? So as long as you're not waiting on a kidney transplant or getting dialysis, anyone can qualify for an Advantage plan. And so you could sign up during the next annual election period and get on a plan. And that's a really good thing about them, is that they're easy to qualify for. It's more difficult to qualify for a Medigap plan. So if you want to go that route, it's good to get that during that one-time 6-month window, which only comes when you first sign up for Part B and then is gone forever in most states.
Wow. So you have to make that Medigap choice during that 6-month window, regardless of if you go with original Medicare or Advantage. Otherwise, you lose it forever.
Yeah, you can only get a Medigap plan if you have original Medicare. So you're deciding right then when you turn 65, am I going to go original Medicare and Medigap or Advantage? Sometimes people will start with the Medigap plan and they know that if it gets too expensive over the years or they feel like they're wasting their money, it's easy to change to an Advantage plan because that has little to no health questions, right? It's more difficult to go the other direction. And statistically, right now, about 34% of all new Medicare enrollees choose an Advantage plan. And you can imagine why. Getting a plan with a zero premium is very attractive. If you can find a doctor in your area or find a plan in your area that your doctors are in the network for, that's great. It's really important to make sure your doctors accept the plan, and also that if it has a built-in Part D drug plan, does it have your drugs on the formulary? You don't want to enroll in a plan that doesn't cover your $400 diabetes Lantus pen or whatever, drug that you have that's really expensive. So you got to do some homework to make sure those things fit. That said, here at our agency, probably 85 to 90% of our clients choose Medigap, and that's because we educate people about, what Advantage plans are all about and the things they need to know. And a lot of times they'll go the Medigap route, but I would say 10 to 15% of our clients do choose Medicare Advantage right out of the gate. And if they're good with that choice, if they know kind of the good and the bad, say the pros and the cons of that, and they know that going in, then those plans can work out really well for them. My best tip on Advantage plans is have some rainy day money set aside, because with Medicare Advantage plans, there are some things where you're going to pay 20%. A lot of times durable medical equipment, you pay 20%. A lot of times chemotherapy, you pay 20%. And although Medicare Advantage plans have a cap on them to protect you from spending beyond a certain limit, that resets every year. So you could have an illness toward the end of the year that causes you to hit your out-of-pocket maximum, and then everything resets in January and you hit it again. You might spend $10,000 in a 6-month period. And if you don't have money set aside for that, you're going to quickly be very unhappy with your Advantage plan. If you know all that going in, you have that money set aside for a rainy day, then it's not a big deal. Or you might be a person that would take the money you would have spent on a Medigap plan and put that into an account every month, saving up for the rainy day. That's also a great strategy. So both choices are good. You just really need to dig into the details and be sure that you choose one that best fits your budget, your needs, and your lifestyle, not just right now, but which one's going to fit you down the line when you might have an illness. You need to think about all those things.
Got it. Hey, one thing I wanted to also clarify, because what you were just describing just made me think of this. The initial enrollment period that we talked about earlier, where there's a penalty if you are delayed beyond that initial enrollment period, does that also apply to Part D for a prescription drug as well, or only B?
It does. So you can sign up for a Part D drug plan during that initial enrollment period. And as long as you sign up then there's not a penalty for Part D. If you don't sign up then and you don't have other creditable coverage, either through an employer or like VA benefits or something, and later you decide to get Part D, you pay a penalty there too. The Part D penalty is 1% per month cumulative for every month that you could have been enrolled and you were not. So if you waited a year and then during the annual election period, you decided to enroll in Part D, when you finally get your plan, they're going to tack on a 12% extra premium, and you pay that forever, 12% per month, every month for as long as you have Part D. But if you waited 5 years, that would be a 60% premium. So even if you don't take medications, it's always a good idea to enroll in at least the most inexpensive plan in your state, the one with the lowest premium, so it doesn't cost a lot out of pocket, both for avoiding the penalty, but also because you can only enroll in drug plans at certain times of year. So if you don't enroll in your initial enrollment period and then in February you get sick and you need a $700 a month medication, you don't want to have to pay that out of pocket all year until you can use the annual election period to get back into another drug plan. And this is important today more than ever because there's oral chemotherapy medications which cost thousands of dollars a month. And some of those are outpatient meds that would fall under Part D. So that's my tip there is enroll right out of the gate unless you have other coverage. And even if you don't take meds, enroll in a very inexpensive plan in your state because all of them have parameters. They have to include 6 classes of very important medications like anti-seizure, antidepressant, anti-cancer, and all drug plans cover at least 2 medications in every therapeutic class. So even if you get a new health condition in the middle of the year, there's going to be something on that formulary that your doctor could choose to treat you with. And then during the annual election period, you could switch to a different plan if you want to. But at least you're covered and you're not accumulating the penalty.
Got it. So during each enrollment period annually, you can ratchet up if you need it, but it sounds like to be on the
Yes,
safe side, just buy the cheapest one, even if you don't anticipate needing it right away.
that's right.
Got it. So the reason I guess I asked this is because you mentioned that if you're on Advantage, you can always go back into traditional Medicare. We'll come back to Medigap in a moment. I know that's a one-time thing, but that if you did switch back over to original Medicare plus Part D from Advantage, there would be no penalty in that case, right? Because you had creditable coverage. Is that also assuming that the Advantage plan had built-in Part D equivalent?
Yeah. So let's say you enroll in Medicare Advantage right out of the gate, and then down the road you return to original Medicare and a standalone Part D drug plan. Because you maintained Part D that whole time since you turned 65, there's not going to be any penalty. You can always return to original Medicare without a penalty during a valid election period. And so then they're looking at, were there any months where you didn't have creditable drug coverage? And so if your Advantage plan included Part D, which like 90% of Advantage plans do, then you would just leave that to go to original Medicare and pick up a standalone Part D.
Got it. So just as you would advise seniors to pick a cheap Part D plan just to be covered so they don't accrue that penalty, if they start with Advantage, would you advise the same? Like find one of those 90% that has a D equivalent rather than one of the 10% that doesn't, for the same
Yeah,
reason?
the only time that I would recommend an Advantage plan that doesn't have a built-in Part D drug plan would be if you have another means of getting drugs. So if you have Indian tribal benefits for medications, if you're a veteran, you get your drugs through the VA, then you could skip the Part D. That being said, my dad is a veteran. He's a Vietnam era war veteran, and he has VA coverage, and I got him a Part D plan anyway, because the VA coverage doesn't cover all medications. It covers a lot of generic medications, and I didn't want my dad to ever have to choose a medication that wasn't the best medication for him because he didn't have that coverage. So to me, spending $30 a month to have the option of filling through a Part D drug plan or the VA was great. But there are many veterans out there that do the Medicare Advantage with no built-in Part D, and they just get their drugs through the VA, and that's certainly an option. And the good thing for veterans is that VA coverage is creditable. So if they change their mind down the line, they can just wait till the next annual election period and pick up a Part D drug plan, and there won't be a penalty.
Okay, got it. So for Advantage plans, that I understand that one of the trade-offs you're making is generally a smaller network. Do they tend to be like at what level of broadness do they tend to operate at? Is it like at a city level, regional, state? They sound like they're not national. How should somebody who's thinking about Advantage think about how broad the network is?
Yeah, so they can be as big as regional, which is usually the whole state. And those regional plans exist on a statewide level so that people in rural areas also have an option for an Advantage plan. But what you need to think about is, where do you get your health care now? So if you always get like I live in Tarrant County, there's tons of Advantage plans here, and some of them have the network is only Tarrant County, or maybe it's Tarrant and Dallas County. Some of them are like 5 to 10 counties in the greater Dallas-Fort Worth area, and so that one's going to probably have more doctors. The cool thing about your mymedicare.gov portal, or even the free plan finder you can use on the generic Medicare website, is when you run the list of Advantage plans in there, you can click through and see how many doctors are in the network. So if you decided to go the Advantage route and you talk to your doctor and he says, I'm in these 5 Advantage plans, any of these will work for me, go and look up all the benefits for those, and then look to see the size of the network. If you have 2 plans that are the same price and the benefits are kind of similar between the 2 of them, and you're trying to decide, you could say, well, this one has 500 doctors, this one has 5,000 doctors. I'm going to go with the one that has the bigger network in that scenario. You're right that they aren't national. So if you move out of the plan service area, you would have a window called a special election period to switch to a Medicare Advantage plan in the new area that you move into.
Okay, got it. Yeah, that was actually my follow-up question. So
Yeah.
beyond everything that I guess we've already discussed, are there any other trade-offs or considerations, whether it's cost differences, network coverage, or anything else that folks should consider when deciding between an Advantage plan versus original Medicare?
I think we've hit the high points. One thing I would always tell you, just from our own experience, is, having had all the people that we've helped over the years, I have found that everyone loves their Medicare Advantage plan until they get sick. And so I go back to that rainy day analogy. If you have a Medicare Advantage plan, and on that plan you're going to pay 20% for chemotherapy, and that plan has, let's say it's a $4,000 out-of-pocket maximum, the most you're going to spend on all of your medical treatment that year, that would be Part A and B, would be $4,000. But your drugs are separate, so you could spend quite a bit more than that. And a lot of times people undergoing cancer treatment will have medications as well. And so that could be a big chunk of change. Well, but you could be on Medicare for 10 or 15 years before you get cancer, and maybe that Medicare Advantage plan would have been perfect for you that whole time. Just think about it logically. Someday we were going to have some sort of major illness or life event. It could be a heart attack, it could be cancer, it could be something else. Have the rainy day fund, put the money away. I'm 46 and I put money into a health savings account every month so that I max it out every month in and month out. And so I hope that by the time I'm 65, I've got like $50,000 in that thing. And that's going to take me a long time to spend down that money. That's a perfect scenario for someone that's thinking about an Advantage plan, but they want to know that in a year, or maybe they'll have more spending on that Advantage plan, are they going to be in good shape for that? So if you apply that rainy day mentality, those are the people that we see end up happy with their Advantage plans long term, because it doesn't surprise them. The ones that decide they don't like their Advantage plans are the ones that have forgotten or never knew in the first place about that risk for some more spending on a year of bad health. And that usually happens when they're overwhelmed and confused by all their choices. They don't work with an agent. They go online and sign up for a plan. They didn't even realize the plan has a network, or they didn't know about the out-of-pocket maximum. And that only happens to you if you don't do your research ahead of time.
Okay, great. So that's really helpful about Advantage. I was wondering if you could also just comment a little bit more about, Medigap and supplemental Medicare insurance in terms of, I know it's more expensive and I know it's meant to cover the overages that original Medicare doesn't get to. But I was curious if you could talk a little bit more about how it works and what kind of costs are involved with Medigap and supplemental Medicare insurance.
Sure. So with Medicare supplements, which are also called Medigap plans, same thing, there are 10 standardized plans. Medicare standardized the plans so that it would be very easy for you to compare. And those plans are A, B, C, D, F, G, K, L, M, N, and a high deductible version of G. And you think, oh my gosh, we have Medicare parts A, B, C, and D, and now you're talking to me about Medigap plans A, B, C, and D. This is too confusing. Well, the good news is statistically, almost no one enrolls in plan A, B, C, or D. By far and away, there have been 3 popular Medigap plans, and those have been plan F, G, and N. Now, if you're new to Medicare and on or after January 1st of 2020, you can't buy plan F, and so we don't really need to go into too much detail on that. But plan G, if you enroll in plan G, you literally have a $198 deductible and then nothing that you pay. So for any Medicare Part A and B covered service, surgeries, doctor visits, knee replacements, physical therapy, durable medical equipment, you're going to pay nothing, 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 nothing.
No deductible, no insurance, no co-insurance, no copay.
No hospital deductible, just the $198 outpatient deductible and then nothing else. That's what a plan G buys you. If I could buy that plan, I would buy it in a heartbeat. My parents, for sure, Medigap plans all the way. My mom is absolutely the kind of person that would make herself sick in the hospital worrying about, well, what's going to come in her mailbox. So I want her to have the plan where she doesn't have it. The costs on the back end are totally predictable and nothing. So Medigap plans work great for that. That's why they cost more, because you have more flexibility, you have more doctors to choose from, you have freedom of access, they're guaranteed renewable. They can't, neither plan, Advantage or Medigap, they can't drop you for getting sick. That's a standard feature built into any of these coverages. But those are the reasons why Medigap plans work well for people. The thing that some people don't like is because Medigap plans were created in the 60s and standardized in the 90s, that was before Part D came into the scene. So they don't include outpatient drugs. You have to add on that separate standalone Part D drug plan, which is an additional premium. So you're paying a premium for Parts B and your Medigap plan, and now a Part D plan, and those things add up. And so you're weighing the cost and coverage factors there to determine that. If someone comes to me at 65 and they have a history of cancer, I'm going to recommend a supplement plan G all day long. But what if we had someone that said, I really like an idea of a supplement, but I'm pretty healthy. Like, I don't feel like I need to buy the most comprehensive coverage. Those are the people where like a plan N would maybe work for them. It has a little less benefits, but then the premiums are lower. So with the plan N, just like plan G, you pay the $198 deductible, and then afterward, you don't have anything else. But on plan N, you do have up to $20 doctor copay, up to $50 ER copay, and excess charges. So if you happen to see a doctor and you forgot to ask, do you accept Medicare's assignment rates? And he's a non-participating Medicare doctor, which means he can bill the 15%, on plan N, you're going to cover those bills. So your premiums are lower, but you're going to do a little more work because you're going to pay copays and you're going to have to ask the doctors about whether they accept assignment. But that's why there's differences in the plan so that you can choose whether you want a really full coverage plan or one with not a lot of coverage. But frankly, even Medigap Plan A, it covers the most important thing. And the most important thing is that 20% that Part B doesn't cover. So Medicare covers 80, even a Medigap Plan A will cover the other 20%. And that's the most important thing. And so then you're looking at the other plans available in there to decide which one has the mix of benefits versus the premium that you pay to fit into your budget.
Gotcha. So it sounds like the most common ones are G and N. What are the premiums for those?
Well, here in the Dallas-Fort Worth area, If you were a female turning 65 non-smoker, you could probably get a Plan G for around $100 a month, and maybe a Plan N would be 70 or 80. So a little bit lesser in the premiums. In some states, there's not a big of a swing in that premium, where you might look at the two and be like, well, why would I buy the N? You know, the Plan G is only a little bit more. And so just depending on where you are, you're going to make that call once you get the quotes that are based on your zip code, your age, your gender, your tobacco usage. Some of them have household discounts. So a lot of it, all those things depend on where the quotes will fall.
I gotcha. So it sounds like, you know, the cost ranges that we talked about a while back, if you wanted to get a Medicare, Medigap on top of that, then you're looking at, you know, ish $100 additional in premium costs. But
Yeah, at least.
Depends on the zip. Got it.
Yep, depends on the plan and the zip and gender and all those things too.
How much higher can it get? Like what's the high end for a Medigap supplement?
So I think probably the most expensive Medigap plans are usually in Florida, and you know, somebody might pay $220 to $250 for the same plan that in Texas would be $100. So for example, Florida is one of the states where you would want to actually consider the Medicare Advantage plans a little more carefully, because there's so many Medicare beneficiaries in that state that the insurance companies all go in and just compete like crazy. So they have created Advantage plans there that are really rich. Lots of zero premium, low doctor copays, low out-of-pocket maximums, lots of extra things like the dental, vision, and hearing. And so in that state, if you have a plan like that with really good Medicare Advantage benefits, and versus a Plan G is going to cost you $220, you know, in that scenario, I might say, hey, are you the kind of person that would take that 220 and put it in a bank account for a rainy day, and know that you're saving that up for your Advantage plan in the future? And that person tells me, yes, I am that kind of person. Great. Let's look and see if your doctor accepts Medicare Advantage. So in some states like that, you may have Advantage plans that are really rich, Florida being the main one. Some good ones in California as well, and a couple of other states. You can look at how the benefits go before you make that choice.
I see. So it sounds like parts B and D have standardized rate cards, but Medigap, it differs based on
Yeah.
your condition and where you live. Is that just because the cost of care differs? Is this correlate with that, or is that for other reasons?
Yeah, it's mostly the cost of care in those areas, and then sometimes the open enrollment rules can affect it. Like for example, in New York, you have the cost of care, but also in New York, they are an all year round open enrollment for Medigap, which means everyone there can wait until they get sick and go buy, go switch their plan. This means the insurance companies are covering a lot more costs than they otherwise would, so they jack the rates up. So you're going to pay more for Medigap in that state. And sometimes when you're looking at that variance, the Medigap plan being a lot more expensive in a certain state, sometimes you look at the Advantage plans and maybe then it looks like a better buy, provided, of course, that your drugs are covered and your doctors are in the network.
How could they do that in New York if there's only a one-time enrollment grace period?
So the one-time enrollment is a federal rule, but the states can improve upon that if they want to. And so there's a few states, and I do have this information in the book and also on our Boomer Benefits website, that have different rules. New York is one of them. For example, California has a rule called the birthday rule. So if in California you have an existing Medigap plan, and around in the 60 days surrounding your birthday every year, you can switch that Medigap plan to a different Medigap plan of equal or lesser benefits with no health questions. So what's good about that is if you get rate increases and then there's another plan that's $10 a month cheaper, you could switch to that plan without having to answer health questions. And that's just a rule that the state legislature in California has built in for that state. What it doesn't do is let you go from an Advantage plan to a Medigap plan. So you've got to already be in the Medigap family. And there's a few states out there like that with a few rules, a handful of them. But for most other people, Texas and a lot of other states, switching would require you to answer health questions and go through underwriting. And, a lot of those people could be healthy enough to change, but sometimes they aren't.
I see. So notwithstanding the federal grace period, that 6-month window that you talked about for Medigap plan that applies at the federal level, once you're in Medigap, it sounds like you can trade in and out between different Medigap plans, but you may have to go through underwriting and may be denied for that reason.
Yeah.
Is that correct?
Yeah, that's right. So here at our company, whenever our clients get a rate increase, we're calling them at 12 months because you with the Medigap plan, just like any other insurance, auto insurance, health insurance, you get annual rate increases. We call our clients around 12 months and say, hey, you should have gotten a rate increase letter. How much was your increase? If their policy went up $5 a month, most people don't want to even bother with the paperwork to change. But then every few years, there'll be a year where it went up 12%. Well, then if we quote other plan Gs in your area and we can move you to a plan that's $20 a month less, if you can pass the underwriting questions, we'll go through those with you on the phone and say, you have a pretty good chance. Let's go ahead and submit, see what the underwriter says. The underwriter is going to see that you answered no to all the health questions. They're going to look up your prescription history, and they are a big brother. They know everything that you've ever taken. They can pull that information up, and they're going to see, okay, is there anything here in the prescription history that doesn't match what they're telling me on the application? They're looking for things that are chronic health conditions, stuff like that. But if there's not an indicator of that and you look like a pretty good risk, they may offer you the coverage. And just because you have a health condition doesn't mean you can't switch. Maybe you take a blood pressure medication or a thyroid medication. Those things in and of themselves a lot of time are not a problem. But some things combined could be an issue. If you have a diabetes medicine and a cholesterol medicine and a high blood pressure medicine, those three together can be a problem. If you have a breathing medication that's indicating that you might have a chronic breathing disorder, that might be a problem. And then, of course, any type of chronic incurable disease, multiple sclerosis, Parkinson's, rheumatoid arthritis, those are things that typically would cause a decline. So that person, we'd be advising them to stick with the plan that they have. That might mean that they're going to keep eating rate increases as the time goes by, but every year they can decide whether they still want to do that or they have the option to look at an Advantage plan if they want to change.
Okay, great. So just wrapping up here, I wanted to just chat very briefly about retirees who, retire abroad. There's more than 500,000 of them, at least, who are receiving Social Security abroad. There's probably more who are actually retired abroad. But Medicare doesn't pay for care outside the US, except in some very limited situations. What are those situations?
Yeah, so it's super limited. Pretty much, they're not going to cover anything that happens to you while you're living abroad. They may cover if you're on your way to Alaska through Canada and something happens to you and the Canadian hospital is closer than a US hospital, they would cover that. If you're in a border situation and the closest care within 50 miles for an emergency is in Mexico instead of Texas, or those kind of situations, very limited situations where Medicare will cover you. But if you live abroad, the question becomes when you turn 65, should you enroll in Medicare? Should you not? You're not sure if you're ever going to come back. If you know for sure that you will come back to the US at some point, then you should at least enroll in Medicare Parts A and B so that you don't have the late penalty. At least then Medicare is covering 80% of your costs, and when you return later on, you have the option for an Advantage plan. I would recommend at least that. If you're not sure if you're going to ever come back, then maybe you don't want to enroll in a Medigap plan. Just have the Part B, because if you say you're not coming back, but later you change your mind, if you only had Medicare Part A, which everyone that enrolls in Social Security has Part A, then all you have is hospital coverage. Well, that doesn't cover chemotherapy or outpatient surgery. So if you did come back to the US needing that care, you would have to wait until the next general enrollment period to pick Part B up. That's from January to March. Well, what if it's April when you figure this out? You've got to wait all the way until the next year to enroll in Part B. The benefits for that don't start until the following July. Depending on when this happens, you could wait over a year to get that coverage, and you're going to be slammed with a 10% late penalty for every 12 months that you could have enrolled. So I typically tell people if it's affordable for you, even if it's a stretch, enrolling in at least Part B is a pretty good bet. And then sometimes what people will do is if they are pretty sure they're going to return to the US, you could enroll in Part B and then a high deductible Plan G supplement. Those are very inexpensive. I think my dad's is 50 or 60 bucks a month, and it covers him. He pays the 20% out of pocket. He pays all of his own Medicare expenses up until a deductible of 2340. But if he hits that, then he's done for the year, and it functions just like a regular Plan G. That's a good option for people that are abroad. They might enroll in a plan like that that's cheaper because they're going to take on a little bit more risk, but at least they have the coverage so that if there's a time when they're coming back to the US because they're sick and they want care here, that's an option that usually works well for people too.
Got it. So it sounds like if you know you want to enroll in Medicare, even if you're retired abroad, either because you know you're returning or because if you get sick, you will return. It sounds like maybe, is it fair to say a good strategy would be to do the enrollment, and then when you're abroad, maybe buy some local coverage that will cover you locally. And then when you return to the US, you kind of come back under the wing of Medicare. Is that?
You bet. Yeah.
Okay.
So if you have an unexpected illness, you can come back anytime and you've already got the Part B in place.
Okay, perfect. Well, Danielle, this was super, super insightful, very, very action-packed. Where can listeners find out more about you, your work, your services, your upcoming book, et cetera?
Sure. We're pretty easy to find online. We are boomerbenefits.com. On all the social media, it's Boomer Benefits. We have a private Facebook group with over 8,000 members called Medicare Q&A with Boomer Benefits. It's free to join the Facebook group. You never have to become a client of our agency, but if you have general Medicare questions, come join us. And I'm in there and my staff is in there. We answer questions for people all the time. And then the book will be available. It's already available for pre-order on Kindle. The paperback will be available for pre-order at the end of next week. And so we priced it at $10 to make it easy for people to learn about Medicare mistakes. And that's pretty easy to find on Amazon. So we would love to connect with you if you are in any of those places.
Okay, perfect. And yes, please send me a link to the book. So I'll link to that in the show notes, and folks can get access to it, as well as the private Facebook group if folks have questions they want to post there. I'll also link to that in the show notes.
Sure.
Cool.
Be happy to.
Thank you so much again for taking the time to chat with us. I really look forward to sharing this with our audience, and best of luck with everything.
My pleasure. Thanks for having me.
Cheers. Take care.